Good evening, everybody. I'm Dr. Michael Atkins, Deputy Director of the Georgetown Lombardi Comprehensive Cancer Center in Washington, D.C., and I'm joined by my colleagues who will introduce in a second, and I want to welcome you to Choosing Innovation with Immunotherapy in Melanoma, which should be a very interesting program. So tonight's panelists include Professor Christian Blank, way over on the left, and Professor Hussein Taubi from MD Anderson. Christian Blank is from the Netherlands. So there are new standards, new choices across the spectrum for melanoma that we'll talk about. And melanoma has undergone a pretty amazing transformation over the past couple of decades. Its incidence is now about 100,000 in the U.S. per year, and an additional 6,000 cases of melanoma, 60,000 cases of melanoma in situ. There are about 7,500 deaths. It represents about 5% of all cancers and 1% of all cancer deaths. So we do a lot better in treating melanoma than we do for most other cancers. It's the fourth most common cancer now in men and fifth most common in women. And it's very interesting that while the incidence of melanoma is increasing faster than all other cancers, the death rate, meaning the number of patients who die each year from melanoma, is also decreasing faster than that of all other cancers. Why? Well, some of that is due to earlier detection, but a lot of it is due to better treatments. And we're going to hear a lot about those better treatments today. Currently, 90 to 95% of patients diagnosed with melanoma are cured of their disease. So back in 2011, as recently as a decade ago, advanced melanoma was known as the cancer that gives cancer a bad name. And that's because its incidence was increasing compared to other cancers. Median survival remained 6 to 9 months in most studies, and less than 10% of patients were alive at 2 years. And there were few, if any, therapies, and the ones we had didn't really impact overall survival. And the number of positive phase 3 trials was around number 0. And these are the survival rates for stages 1 through 4 of melanoma in 2011. And we're going to focus on stage 4 melanoma, which has this dismal survival curve, and also stage 3 melanoma when we talk about some of the adjuvant and neoadjuvant studies, and a little bit into stage 2, where there was room for improvement that we're now seeing. But today, because of these new therapies, even with metastatic melanoma, over 50% of patients are predicted to survive long-term, so there's no longer any median survival. And the reason for that are the therapies shown on this slide that we're going to hear about. Therapies targeting BRAF and MEK within the tumors, immune checkpoint inhibitors, particularly CTLA-4 and anti-PD-1 blockers, and we'll hear also about LAG-3 inhibitors. Treatment of CNS disease, which used to be almost the common endpoint for patients with metastatic melanoma. They die of CNS disease, and we're doing a lot better in terms of controlling that, and adjuvant and neoadjuvant studies. And we're going to do this as a case-based discussion. So we're going to have clinical consult sessions, mixing these case-based discussions and mini lectures on the new developments within immune checkpoint inhibitors in metastatic melanoma and in various disease settings, and the changing role of adjuvant and neoadjuvant immunotherapy in resectable disease. So I think we're going to go to a case, and Dr. Taubi will be discussing this. So this case is a patient with stage 4 melanoma and lung metastases. It's Richard, and Richard is a 58-year-old male with stage 4 melanoma with multiple unresectable lung metastases. In addition, he has a BRAF wild-type tumor, normal LDH, performance status 0, no visceral or brain metastases, and has no prior adjuvant therapy. So the options that one could consider are single-agent anti-PD-1, anti-PD-1 plus anti-CTLA-4, or anti-PD-1 plus anti-LAG-3. I'm going to turn it over to Dr. Taubey to discuss.
Thank you so much for the introduction, Mike, and for all of you for being here this evening. I think this is a very good start. This is a patient that you would consider a pristine treatment-naive patient with a low tumor burden and just what we call M1A disease because it's lung metastases. So what we're going to do is go into the current NCCN guidelines, the current kind of guidelines for what are approved therapies in each of the first line and the second line, and discuss some of the data that has resulted in these recommendations. And then we'll go into kind of how do you apply those to the patient that we presented and in your clinical practice. So what you see on the left is all of the first-line therapies, and if you note, there's actually all of them are category 1 because in reality, all of the phase 3 trials that had led to approvals of these drugs are all actually in the first line. So you look on the right side, and we have the second line or subsequent therapy, and we'll go through that as well. And not a single one of them is actually a category 1 because we don't have randomized phase 3 trials in the second line setting. So in a first-line setting, we talk about PD-1 monotherapy as the Nivolumab or Pembrolizumab. Now we have dual checkpoint inhibitors. We've had Nivo-Ipi for also the good part of a decade, but we just had Nivo and Relatlimab FDA approved back in March. And we obviously have 3 different combination therapies for our patients with BRAF-Mutated melanoma. There is something that's not currently on the list and will be part of our discussion is when you add PD-L1 to Vem and Cobi as well. That's a phase 3 study that's approved in the first line. And again, this will be part of our discussion briefly. Now, whatever you choose for your patient in the first line, obviously, our patients do respond, but we still lose about half of our patients, and about half of, half of the patient will require a second-line therapy. And so in the second line, of course, if your patient was, say, BRAF-mutated and had not received PD-1 therapy at all, you can actually consider PD-1 monotherapy, and then there was some recent data about the use of Nivolumab and Ipilimumab in the second line. There's some data for Pembro and low-dose Ipilimumab in the second line. And again, for your BRAF-mutated patients, if they had received immunotherapy in the first line, that's when you can go to BRAF-targeted agents. And so we're going to review some of the data behind these recommendations and actually start with one of the kind of most enduring trials, which was the study that compared KEYNOTE-006, which is the phase 3 trial that compared Pembrolizumab to Ipilimumab. So Ipilimumab was our first approval in melanoma, the first phase 3 trial that has led to improved survival, and we know cures about 20 to 23% of our patients with melanoma. Pembrolizumab was compared at 2 doses, by the way, in that study, and they're combined here in the blue curve compared to the orange curve, which is Ipilimumab, and this is the overall survival. So what we know is that the objective response rate to Pembrolizumab is in the 35 to 40% range. The median PFS was definitely better. Importantly, we now have 5 and 7 year data for first-line Pembrolizumab, and we know that again what we consider a bit of a cure rate is about 40% for single-agent PD-1. The other thing we learned from the early studies is you can actually discontinue treatment. So being part of KEYNOTE-2, I can tell you that we had the treat until, progression, and our patients would respond, and then at some point you would ask, how long do we continue this? And the reality is we don't have to continue treatment when patients do get a really great response. And so this is the data that shows that for patients that can discontinue treatment after 2 years, this is about 100 patients, especially those that get a CR or a PR. Those are really durable. I mean, once you get your immune cells, your immune system activated, recognizing tumor, destroying tumor. This is, again, akin to a cure. We still have to do a little better for our patients with stable disease, but again, this is kind of a situation where we might need to think about why are these patients progressing, at a later time. The pivotal trial that established dual checkpoint blockade as a standard of care in melanoma is CheckMate 067, and this was the study that compared nivolumab in combination with the CTLA-4 ipilimumab to ipilimumab alone. It also compared nivolumab to ipilimumab, and always very important to remind everyone that this study was never designed or powered to test Nivo-Ipi versus Nivo alone. It was, both of them were being compared to ipilimumab. And so I think this particular slide really summarizes the entire field for the last 10 years, or 6.5 years to be more exact. So I told you about Ipi being about 23% long-term survival. Told you about single-agent PD-1 being about 40% long-term survival. And the combination of Ipi and Nivo now gets you above 50%. In fact, our median survival based on this study is now 72 months if you treat patients with Ipi and Nivo. However, I should tell you that, again, this is waiting 6.5 years. The median age, or usually the age of those patients getting on studies, are in the 60 to 65 range. So this is not all death from melanoma. If you look at the melanoma-specific survival, so those patients died of other causes too, it was actually 56% melanoma-specific survival. So again, we're doing really well for those patients. I will also just briefly mention, which I discussed in my talk this morning at ASCO actually, is the fact that, even with the fact that this was not powered to detect a difference, there was a numerically S for Ipi and Nivo versus Nivo alone. The hazard ratio for survival was 0.84. It wasn't statistically significant, but again, about a 16% decrease in survival. Now, what's the problem with Ipi-Nivo? We all love it. We were on the shuttle coming here, the three of us, and talking about how we love it for our patients, because no matter what toxicity we experience, we really cure patients with this combination, sometimes with 1 or 2 doses. The problem that we deal with is that we induce a ton of toxicity. The way I explain it to my patients is, PD-1 obviously makes T cells more effective. CTLA-4 just widens the scope and allows them to see more things. And so when you have T cells that see more things and T cells that are now being made very effective by PD-1, you end up having more normal structures that are attacked by the immune system. So the rate of grade 3/4 toxicity is to the tune of 59%, which is quite high. In this study, nivolumab alone had about a 24% grade 3/4 toxicity. And ipilimumab is what we had expected. Again, it's a 20 to 30% toxicity typically. So we do well for those patients, but they do experience a lot of toxicity. And the search continues to find approaches that could actually give us the same benefit, hopefully with less toxicity, including, and we can discuss this perhaps in the discussion, giving lower doses of Ipi. That's one way you can have less toxicity. But Relatlimab, or the anti-LAG-3, is the newest agent. And again, LAG-3, as so many other checkpoints that are being studied, right? There's STIM3, LAG-3, there's VISTA, TIGIT, basically those are checkpoints that are expressed on T cells at various levels of T cell effector development and then exhaustion. And so LAG-3 is a marker of T cell exhaustion. It is frequently co-expressed with PD-1 on exhausted T cells. And so the idea of being able to block that and perhaps make exhausted T cells, kind of reinvigorated and capable of killing tumor is the reason that this combination was developed. Interestingly, just one thing for you to learn from this slide is that the ligand for LAG-3 is MHC class 2. You know how like PD-L1 and PD-L2 are the ligands for PD-1. LAG-3 has MHC class 2 as its ligand. And then when you block it, again, there's a couple of, the original studies were actually in PD-1 refractory disease, or, in this case, in terms of resistant disease, and had shown in a phase 1 trial that you can induce with a combination of nivolumab and relatlimab, you can induce immune-mediated responses that are durable, but at a low rate in the second line. It was in the order of about 10 to 13%. But taking it to the first line was the Relativity 047 trial. And this was a randomized phase 2/3 study that took treatment-naive patients, good performance status, and randomized them 1-to-1 to the fixed-dose combination of relatlimab and nivolumab versus nivolumab alone. The randomization was stratified by LAG-3 status, PD-L1 status, BRAF status, so really kind of accounting for what we think or what we thought going into it could be biomarkers of response, and also the M stage. The primary endpoint was PFS, and actually different than CheckMate 067. The PFS was blinded independent central review. All of CheckMate 067 was actually investigator assessment. And then secondary endpoints were OS and objective response rate. And so the top-level results that were reported last year with about 13 months of follow-up was that the PFS endpoint, which is the primary endpoint of the study, that's what the study was designed to and powered to detect, was actually in favor of nivolumab and relatlimab with a hazard ratio of 0.75, which translates into 25% decrease in the rate of in the risk of progression or death on treatment compared to nivolumab alone. The hazard ratio that was highly statistically significant with a p-value of 0.006. And I note a couple of things. The median PFS was almost double, so 10 months versus 4.6 months. The one-year landmark of 48% PFS is actually quite similar to what we see from CheckMate 067. It was exactly 49% with Ipi/Nivo and CheckMate 067. So this study was a phase 2/3, so there was actually a 6 months pause after the first enrollment, and so there was a lot of censoring in this part of the curve, and we were interested in seeing whether with longer follow-up that would change anything, and in fact it didn't. So the PFS remained very consistently better. The hazard ratio was the same, 0.78, and was statistically significant. When we looked, this was the first look at OS, and again, the study wasn't powered to detect the difference in OS. It was a secondary outcome. But you see an early separation, and we saw a hazard ratio of 0.8, indicating a 20% decrease in the risk of death. But it was close but not statistically significant, 0.0593. And as I pointed out this morning, a ton of censoring in that 1 to 2 year range as well. So we will never be able to test statistically anymore. This was the final analysis for OS, so I don't think I'll ever be on this stage saying there's a statistically significant difference. But, you know, if those patients end up following the same pattern we're seeing, it could be that we'll see a survival difference. We have a higher response rate with the combination, 43% versus 32% for nivolumab alone. And when you look at all of the different subgroups that we'd be interested in, PD-L1, LAG-3, if you look at PFS and OS, everything was to the left of 1, indicating that this was Nivo-Rela was better. As we get into subgroups, you start seeing these wide confidence intervals across one, obviously because subgroup analyses, you know, make you lose a lot of power. So we started looking at response rates, and you see with PD-L1 positive, for PD-L1 positive patients, the response rate was 53%. If they were both LAG-3 and PD-L1 positive, it was 55%. Obviously, if you're PD-L1 negative, we always see less response to immunotherapy. But again, if you're LAG-3 positive and PD-L1 negative, that was the biggest difference. The response difference was 14%. I won't comment on the last one because we have like 70 patients in that group. When we looked at things like age, it kind of really didn't matter. We're really excited to see that there's a significant, well, I shouldn't say the word significant, but a large difference in response rate for acral melanomas. We see about a 30% versus 11.9. BRAF mutation, which is very relevant to our discussion tonight, didn't make any the same response rates, whether patients had BRAF mutant melanoma or not. I also showed the PFS and the OS today, and again, they look pretty identical. The reason we're all excited about this, well, one, we have a new option. Two, it's a different agent and a different checkpoint, so perhaps we're going to be able to tackle resistant patients that would have been otherwise resistant. But also, the third thing is that it's a lot safer than the dual checkpoint with Ipi/Nivo. And we see a toxicity rate. This was the original report. Actually, the updated number is about 21.1%. With Nivo alone, it was 11.1%, and Mike brought it up today in terms of why it was so low in nivolumab alone. But it's obviously a really favorable toxicity profile. So in terms of toxicity, I don't want to take up too much time. I'll just say very quickly that I think we've gotten to learn how to manage toxicity. For grade 2, we withhold. Sometimes we start steroids if the toxicity doesn't resolve within a week or two. But if we face grade 3, 4 toxicity, high-dose steroids are always your first recourse, and holding or discontinuing immunotherapy. And if this doesn't resolve your toxicity, then you may have to include other agents like anti-TNF or even mycophenolate, usually for hepatitis. The question of whether you re-challenge after toxicity or not is a bit complicated. It kind of really depends on the response you've got in the first place, and then whether you think you really need to continue treatment or not on those patients. So going back to this patient.
So how would you treat this patient?
So what I showed this morning, I wasn't on this slide. I told you this would be an M1A patient, and if you with a normal LDH, with Nivolumab 3, we actually have still about an 11% increase in response rate for Nivo-Rela versus Nivo alone. So for that much of a benefit with a few percentage points more in toxicity, I would favor Nivo-Rela for this patient as well.
Did you want to add anything, Christian, or do you want to do surgery?
Yeah, I think if you think in the first-line treatment, then I agree with Hussein. If you think in treatment sequences, and you have just shown that Ipi-Nivo after failure from Nivo-Rela is not giving any responses, I might even consider to start with anti-PD-1 only. It's a normal LDH patient, no brain, no visceral. There you have more than 50% response rate. And we know that after failure of anti-PD-1, we have an additional 30% of Ipi-Nivo. So if you calculate this together, then you can come to up to 80% response rate. So this might be also an option. But this depends also whether the patient has symptoms and wish. If you want to go for a higher response rate, then I would definitely go for the doublet. But if you think in sequencing, then you could also start with anti-PD-1 only.
Did you want to comment on
No,
that?
the one thing I'll say is nobody in this room is wrong. I mean, you can do single agent combinations, but we're going to work hard on making the not so sure people very sure of their choices later. So
Okay. We're going to go forward. So I think we've changed the case a little bit. Now Richard, it just turns out, has a BRAF mutation in his tumor. They rechecked, still has a normal LDH, performance status 0, no visceral or brain metastases, no prior adjuvant therapy, still with just those unresectable lung mets. And now we've got some more options to consider, such as BRAF-MEK inhibitors and those 3 combinations that Dr. Taube mentioned. The same choices, anti-PD-1, CTLA-4, anti-PD-1, anti-LAG-3, the triplet of anti-PD-L1 plus BRAF-MEK, or BRAF-MEK inhibitor, 2 anti-PD-1, CTLA-4, sort of like a sandwich approach. So take it away, Hussein. How would you handle this new finding in this patient?
Yes, so let's review some of the data. With BRAF-MEK, again, we have more options, which is always a good thing. But then the idea is, how do you actually, just like, Christian just said, you have to kind of play the long game and think about how are you going to sequence those options and those therapies? How do you give your best therapy up front and then, kind of be prepared with the salvage therapy if possible? So I'll go relatively quickly because we laid, I think, a good foundation with the immunotherapy data. The idea here is any of these combinations are all, combining a BRAF inhibitor that's very specific. Both dabrafenib, bemrafenib, and encorafenib are specific to the mutant BRAF protein, and then combining it with a MEK inhibitor, which has already shown that it's actually not just more effective, but actually limits the toxicity of the single-agent BRAF inhibitor. So we have those 3 combinations. We know from all of these 3 combinations that you have a very high response rates, always in about 65 to, let's say 65%. 90% will have a response, but 65% will be an objective response. We also know that about 20% will have long-term survival. So it's not just that BRAF-MEK inhibitors are an immediate fix and then everybody progresses, but the fact is you can still have a long-term survival. Generally, the PFS is in the order of about a year between all three combinations. And then when you look at these curves, they're really comparable between the three combinations. One thing to mention here is the better the response you get with targeted therapy, if you get a CR, that's more durable than a PR, which is, might sound intuitive, but the data is actually very consistent with that. And so that kind of creates a conundrum, because if you think about does immunotherapy work differently or more effective in one type of BRAF mutation versus another, or whether you have wild type or mutant? Well, actually, Ipi/Nivo seems to give a bigger kind of benefit compared to single-agent nivolumab in BRAF mutant patients, where you see the PFS curves and the OS curves look very similar between the BRAF wild type, between Nivo and Ipi versus Nivo alone in CheckMate 067. So that actually makes it even harder for a BRAF mutant patient, because guess what? Ipi/Nivo is actually even more effective. So it doesn't make it a lot simpler of a choice. This is why we can't keep comparing phase 3 trials all ran in the first line against each other without comparing those drugs directly to each other. And this is the study that Mike Atkins really wins the most resilient melanoma investigator of all time, because he started this study many years ago and finally managed to get it finished and really changed the way we think about this. I would say that all of us as melanoma oncologists are kind of immunotherapists at heart, and we all kind of knew that we have the more durable responses, like Christian was saying, that you want to get the best cure for those patients. So we used to favor immunotherapy, but the reality is we never had a head-to-head comparison. And this was at DREAMseq, was Ipi/Nivo first, and then at progression you switch to the dabrafenib trametinib, or the dabrafenib trametinib first, and then at progression you switch to Ipi and Nivo. And what this showed is what you expect in the early phase, which is that the BRAF-MEK inhibitors will do better up front. They will give you more responses, but then, you always have that mythical drop in immunotherapy-treated patients in the first few months where people progress. But in the long term, at 2 years, I keep telling Mike Atkins, this was not a subtle study. This was a very positive study in favor of Ipi and Nivo, a 20% overall survival difference at 2 years in favor of immunotherapy first. So again, we have Mike here, so we'll ask him his final opinion. Very quickly, this is not the only study looking at BRAF-MEK versus, to start with, versus immunotherapy. SECOMBIT did about the same. It had 2 arms that looked pretty similar to DREAMseq, but one arm was different, which is arm C, and it had a planned switch from BRAF-MEK after a 2 months induction, so to speak, to Ipi/Nivo, and then if those patients progress, then they can go to encorafenib, Ipilimumab². This study is very underpowered. That's the first thing I want to say always, although it did show that the patients that start with BRAF-MEK first and then you wait until progression seem to do less well than patients that have immunotherapy either first or after 8 weeks of treatment. So, kind of also indicates that we probably need to start with immunotherapy first. We can't ignore the fact that we have another triplet that's approved in the first-line setting. It's Atezo, Vem, and Cobi, and this was IMspire 150 that shows a PFS benefit for triplet therapy up front. And so we still don't know what to do after patients progress. Again, there's some data for low-dose Ipi/Pembro. We just heard S1616 at AACR, where high-dose Ipi/Nivo gives you about a 30% response. We're getting interesting drugs like Pembrol and Nivolumab in the second line. TIL therapy is proving to be an option that could be really important for our patients. The other thing that we really don't have a very good solution for is the other genomic alterations that can affect BRAF that are not a mutation, or class 1 BRAF mutation that change exactly that V600E. All of these BRAF inhibitors were designed around the mutant BRAF V600 location, but the reality is we have a small proportion of patients that have BRAF amplifications or class 2 or 3 BRAF mutations, and thankfully we actually have an interest in the field that there are pan-RAF inhibitors that are being developed, like KIN2787. There are some even brain-penetrant BRAF inhibitors that are being considered, so that field continues to evolve, and hopefully we'll have more effective agents in the future.
So we're coming back to this case. What do you think?
Well, I mean, I think it's as you know, and I'm interested in hearing Christian's thoughts as well. I think DREAMseq for us melanoma oncologists is a very clear indication that the debate is over. Immunotherapy first. I mean, at all, and now you could argue that it wasn't single agent, but then we choose single agent or Nivolumab based on multiple factors that are typically low tumor burden, low LDH, and other factors that actually make immunotherapy more effective. So from my perspective, immunotherapy first is a very clear answer. Christian?
Same for me, yeah. So it's nice to see that the idea that we had before, supported by DREAMseq, are really implemented in the field.
Let me give you one more reason to consider immunotherapy first. Here, let's talk about this patient.
Okay, we want to move forward. So this patient is patient with a now multiple unresectable lung and brain metastases, still BRAF-mutated tumor, has a high LDH rather than a normal LDH, but his performance status is still 0. No other visceral metastases, no prior adjuvant therapy. And we have options to consider, including single-agent anti-PD-1, anti-PD-1 CTLA-4, anti-PD-1, anti-LAG-3, and there are probably other options that aren't on this list. So go ahead.
Like BRAF inhibitors. Well, I'll again, before DREAMseq, I used to present the data that you're going to see now to say this is the one situation melanoma or immunotherapy is clearly favored, which is brain metastases. So we know that immunotherapy is effective in the brain. We know that when you want to make an effect in the brain that's the highest response you can get, you really need combination. This is the ABC study that actually used single-agent nivolumab on in arm B, and the response for single-agent PD-1, both pembrolizumab and nivolumab in the brain is only about 20%. You know that outside the brain we were saying about 35 to 40%. In the brain it's only 20%. But when you do Ipi-Nivo together with the high-dose Ipi, Nivo, you get the response, the same response in the brain as you get outside the brain, 59%. And every time you induce a response in the brain with immunotherapy, the result is usually durable responses. So you see this overall survival and the PFS curves. This is CheckMate 204, which is again Ipi plus Nivo, and it was a single-arm study in patients with asymptomatic brain metastases, and we had a 58% response. And what you're seeing here is the 3-year PFS, which hasn't reached the median yet. So very durable response. If the patients are symptomatic and requiring steroids, immunotherapy doesn't work very well. We get only an 18% response. But every time you get a response, it's durable again. So that's why these PFS curves are pretty steady, although they're relatively low. When you do targeted therapy, only the BRAF and trametinib has data from a prospective study, and it has a high response rate in the brain again, so 58%, almost the same number you get with Ipi-Nivo, but the PFS is a lot shorter, is exactly half in the brain what it is outside the brain. So if you face a situation where your patient needs treatment very quickly, you can get a response in the brain immediately within a few days to weeks, but it will progress very, very fast. And this morning, Reinhard Durmer presented triplet therapy in the brain mets, and I can tell you that in asymptomatic patients, it wasn't very exciting. The response rates were around 50% as well. The PFS wasn't better than what we saw with the BRAF-Mutated trametinib alone, 5.7 months. But what was really helpful is for those symptomatic patients, because the regimen is Vemcobi, and then you add Atezo after 4 weeks. So we managed to take almost half of the patients that were on steroids, we managed to take them off steroids. And when you added PD-1, it seems that the response rate was, again, in the order of 58%, and the PFS, or the duration of response, was now prolonged into 10 months. So we're really excited about those results, and we may start to make some headway in symptomatic brain mets.
What do you now think about the optimal choice for this patient? Dr. Taube, what would your choice be?
I will follow DREAMseq and say Ipi-Nivo first. But again, I think in our patients with brain metastases, even Nivo-Rela at this point, we have 0 data in the brain. So it's our most effective approach. Christian?
I think I agree with that knowledge on that, but I would have asked 2 questions. Is the patient symptomatic, and is the patient using steroids? We know that patients with steroids, you've shown this also, and Reinhard Durmer has also early on shown data on Ipi only, that then the response drops dramatically. So then these patients you might want to give a pre-treatment, and these are the IMNet-show patients that you give maybe BRAF-MEK upfront and then switch very early on, even that we don't have very good data on that. But I think for immunotherapy, you would like to have the patients steroid-free, otherwise you push the gas and the brake, yeah.
So, Dr. Taube, if this patient had symptomatic disease and was on steroids, would you use that triple combination, or would you do the doublet and then switch to an Ipi-containing combination?
Yeah, honestly, that's a pretty big question. The one thing I'll say, which is really interesting, is if you think about what is causing the symptoms. If it's one lesion that's causing the symptoms, you can consider actually surgical resection. And there was a paper from the Mass General group that showed that you do that, you take the steroids off, you treat with Ipi-Nivo, and you get almost the same survival. So there are other ways to handle the symptoms that could put you in a place where you can harness the benefit of Ipi-Nivo.
Yeah, I can comment because one of those 4 patients
was you.
In the symptomatic group actually presented with a large brain met and several small brain mets and had the large brain met resected, came off steroids the day before we started him on the CheckMate 204 study and had a complete response in the brain, had his systemic disease also respond, and is now 5 or 6 years later and is riding a bike in our cancer center bike fundraising activity. So
there you go.
Oh.
So, but I think it was important that he had the big mass resected, was able to get off steroids before he got the immunotherapy. So anything anyone wants to add, or should we move on to the second half? Okay. Great. We're moving forward. And this is going to focus on adjuvant and neoadjuvant choices with immunotherapy in resectable melanoma. And Professor Blank from the Netherlands Cancer Institute in Amsterdam will be taking the lead. But first, let me present a case, which is Jessica. And Jessica is a 6-year-old woman with a resected stage 3B melanoma. It's BRAF wild type, performance status 0, and she has no history of any autoimmune condition, not on steroids or anything that would prevent immunotherapy. So what would you consider for this patient? No adjuvant therapy, adjuvant radiation therapy, adjuvant anti-PD-1, or adjuvant anti-PD-1 CTLA-4 combination. Go ahead, Christian.
Good. Thank you for the invitation first. Meanwhile, we are also in the adjuvant situation, in the luxury position that we have several choices that we can do. First of all, we have the trial Ipilimumab that was compared to placebo. That is the 10 milligram per kilogram Ipilimumab, which was pretty toxic. Therefore, it was only approved by the FDA in the US. It has never made it to the EMA in Europe because in the streamlining, the anti-PD-1s came also with Pembrolizumab and Nivolumab. You see here the trials. Nivolumab was compared to Ipilimumab. Maybe I should go back. Ipilimumab was positive, 0.75 hazard ratio against placebo, FDA approval 2015. The Nivolumab was compared to Ipilimumab, also a very nice hazard ratio, and then FDA approval 2017. And then we had anti-PD-1, the second anti-PD-1, Pembrolizumab, now compared to placebo again. So be careful when you judge the hazard ratio with a hazard ratio of 0.57 in 2019. When we calculate the hazard ratios from Ipi versus placebo and the Nivo versus Ipi, then you come to exactly the same hazard ratio than what Pembrolizumab has against placebo. And for the targeted therapies, we have Dabrafenib compared to placebo with a hazard ratio of 0.47, approval in 2018. The NCCN guidelines give them all a good staging for stage A to 3A to D, sentinel node positive, and now you see the HCC 8 criteria, while all trials use the HCC 7 criteria, but for all of them is a preferred in this one. Clinical node positive, all category 1, stage 3 in transit, only for Nivo, the category 1, and Pembro preferred, Dapcham preferred. So here you see now the long-term follow-up from CheckMate 238, the trial that compared Nivolumab versus Ipilimumab. It's hard to see. And there you have a statistically significant relapse-free survival benefit, now with a median at 52 for Nivo and 24 for Ipi, hazard ratio 0.71. And if you look at the events here now with the update, you have 61 versus 24. So really a strong benefit for the anti-PD-1. And I remind you also the toxicity was lower for that. Then we have the Keynote 054 trial, the EORTC 1325 trial. And the difference in this trial was that it was compared to placebo, but it allowed a crossover for these patients. So in this trial, it will be hard to show an overall survival for only the upfront treatment. But if you think in a sequence, then this is a very attractive trial because this trial addresses the questions, do we have really to treat upfront all patients, or can we post-surgery wait till the patients have really relapses and then treat them? Very nice data, 63 versus 44% alive and recurrence-free at 36 months. The adjuvant immunotherapy is effective regardless of the BRAF status. Our lady has no BRAF mutation, but we will have, I think, a case that we have this. But you see now here that this is no difference. And this is also shown in the for Keynote 054 for Pembrolizumab. So is there a role for adjuvant dual checkpoint inhibition? We have not had a big trial with the standard dosing, but we have the Immunet trial from Dirk Schadendorf, an investigator-initiated trial that showed clearly that Nivolumab, Ipilimumab gave a higher response rate than Nivolumab or placebo, and this were resectable stage 4 patients. The CheckMate 915 trial was negative, but this one used a different scheme, and there's a big discussion whether this changing in this scheme was the reason that this trial became negative, and that we have these contrary data from the Immunet versus the CheckMate 915 trial. Here we gave adjuvant Nivolumab to 40 Q2 weeks, but Ipilimumab only 6 weeks, and all data before were done with Q3 weeks application of Ipilimumab, and the plateauing occurs also after 2 courses Q3 weeks. So it could be that in this trial the plateauing was not achieved, and therefore this trial was negative, which is surprising that then melanoma would be different to lung cancer, because this scheme is very effective in lung cancer. We have no approval and we have no standing at the moment for the double checkpoint inhibition, at least in the adjuvant. You will see it, that I believe in the neoadjuvant setting we will see this soon. Adjuvant radiotherapy has never shown to improve overall survival, but if you have a very complicated area where the surgeon says, I never will want to reoperate this patient anymore, then you might consider this, because there is definitively shown for adjuvant radiotherapy the local regional control. So this is something that where radiotherapy has the only standing anymore in the adjuvant checkpoint era.
And Dr. Taube, you want to add anything?
I actually want to highlight that the choice of no adjuvant therapy is actually a decent one. I mean, I think that's also one that needs to be discussed with patients, and it's not wrong not to treat. I mean, if you even looked at that placebo curve, you know, there were 44% of patients for KEYNOTE-54 that never recurred with surgery alone. If you look at the COMBI-AD, there was 37% on the placebo arm that never recurred. So I just want to highlight that's also an option, and that's why we discuss with the patients, you know, what is their preference for toxicity and their tolerance for it as well.
I agree with you. And adjuvant therapy should have the intention to improve the overall survival. We still have no overall survival data. We have it only for Ipilimumab, but at that time we haven't had so much subsequent therapies. Now we have also for relapsing patients an excellent possibility. So therefore, I think the benefit from adjuvant therapy concerning OS will be very small. Yeah, this needs to be discussed also with the patient. Yeah.
And what do you think about Nivo-Rela? Will we be seeing those studies soon? And is that going to be a good place for one to consider that combination? I
think with the toxicity profile, which is definitively lower than Ipi-Nivo, it might have become a good standing. I would wish then that we would find some biomarkers where we say, okay, this patient should get adjuvant anti-PD-1, and this patient needs really the doublet therapy, because the toxicity is still higher than anti-PD-1 alone. And therefore, you would like to advise the patients wisely.
Yes, and Dr. Taube is nodding. So we're going to move on, and we've changed the case a little bit. It's now a stage 2C melanoma, and BRAF wild type still, negative sentinel lymph node biopsy, so that qualifies it as stage 2C. Otherwise, good performance status, no autoimmune condition. And so how about now? Options are no adjuvant therapy, adjuvant RT, adjuvant anti-PD-1. So go ahead, Christian.
Okay, thanks. So here you see now the HCC 8 edition, what we discussed already. And what you see is that the 5 years overall survival for 2C is 82%, but it drops at 10 years to 75%. And if you compare this to stage 3B, which we almost at all MDOs say you have to give adjuvant therapy, then the outcomes are identically. So the HCC criteria are in that way not picking the right prognosis of these patients, and Jeff Gershonwald will correct this once hopefully in HCC 9 or 10. But at the moment, a lower number that suggests a better prognosis to the patient is the same prognosis with like a higher staging. In that way, I think that these patients should be also treated in the same way like the 3B patients. So we have now one ongoing trial, the CheckMate 6K, that included stage 2B/C melanoma, resected, and then starting the adjuvant therapy within 12 weeks, no prior tumor, and good performance status. 1,000 patients included. In the primary endpoint is relapse-free survival, and these patients are randomized to placebo or 12 months Nivolumab flat dosing at 480 milligrams every 4 weeks. And we have the KEYNOTE-716 trial. The key eligible criteria were similar and randomized to Pembrolizumab flat dosing 200 milligram Q3 weeks, and in an adjustment in a weight adjusted for pediatric, comparing to placebo. It's interesting that this trial was still decided with Q3 weekly, while we meanwhile give Pembrolizumab 6 weekly. So it's a history of the Pembrolizumab compound that we always give it at the end in a different scheme than what we've done in the trials. Yeah, and if the patient's recurrence, then they can have a rechallenge and crossover for sure. Here you see now the 12 months data, and we have 54 events in the Pembro arm and 82 in the placebo arm, giving a hazard ratio of 0.65, thus strongly statistically significant in the hazard ratio. But if you look in the absolute numbers, it seems that despite AGC suggested, it's a pretty good outcome of the patients with a 90% 12 months relapse-free survival rate and only 7% lower for the placebo arm. And the problem with so many possibilities of subsequent therapies is that I think these small differences will never translate into an overall survival difference, because we have so many patients that will be picked up very early. In trials, adjuvant trials, the follow-up control is even better than what we do in standard therapy outside the trials. So you will pick up very early, low tumor burden patients that are excellent patients to receive adjuvant therapy. In that way, this high frequency follow-up in trials actually makes placebo arms better than they would be in the reality. If you look into the subgroups, all patients subgroups benefit from adjuvant pembrolizumab, and therefore I think I don't want to skew the.
What do you think, Christian?
I have not mentioned that in the stage 3 we had a 20% absolute difference, and we still don't see overall survival now very long, 5 years follow-up. With an 8% difference, it will be even harder. So in that way, giving no adjuvant therapy or giving adjuvant therapy is definitively a good choice. You should discuss this with your patients. A patient that is very anxious of a relapse, you definitely should give the adjuvant therapy. A patient that is very anxious of adverse events, you might be very good off also not giving it, and then waiting whether the progression comes, and then advise the patients to do this. So very smart answers of the audience here.
So Dr. Taube, there was data presented today that you didn't emphasize, Christian, about differences in distant relapse. So I saw the numbers on the slide. There were pretty significant difference in distant relapse. Does that make any difference to you?
Well, I mean, I think what's very clear is anti-PD-1 antibodies are able to, kind of eliminate micrometastatic disease. And the question is, how high is the risk of your patient to develop that? So I just want to mention that when we say 2C or 2B, not all 2Cs and 2Bs are the same, because once they're 4 millimeters and ulcerated, you say this is stage 2C. But honestly, I had someone in their 60s who had an 11.5 millimeter tumor. I mean, those are the 2Cs that I, really think hard about treating. But, if I get someone who's 2.05 millimeters ulcerated, that's a patient I'm going to consider not treating. So I think we have to be flexible about the risk prediction and hopefully develop better predictors. And just think about immunotherapy as an option that you have for those patients that you're either really worried about, or just like Kirsten said, if they're really worried and they say, no, I want you to treat me, technically the indication exists and you can't withhold that therapy if the patient kind of requests it.
Yeah.
One more question for you, a twist on this, Christian. Do you think the patients are actually being cured by the adjuvant PD-1, or are we just delaying relapse or recurrence?
Oh, that's a really challenging question. We know that micrometastases are less immunogenic than microscopic disease, and in that way, there's a good chance that you have a micrometastasis that is sleeping and despite of the immunotherapy. And what is funny to see is, and if you look into the distance metastasis-free survival data, we have this big difference in favor of pembrolizumab in the lung. But this is an area where we know already that immunotherapy works very well. So there are also, even if you develop lung metastasis, that you then have responses. But vice versa, you saw in the patients that were treated with pembrolizumab, only in these patients suddenly adrenal gland metastasis. And adrenal gland seems to be such an immune escape area like what we see in the brain also. This is often seen that if you escape from immunotherapy, that you have an adrenal gland metastasis. And funny enough, you see this. So it could be also dangerous that you culture a clone that knows where to hide when you give it too early. But you know, at the end, the overall survival data and somehow also the patient choice should play a role at the end. Yeah? So now we have first take-home messages from adjuvant immunotherapy in melanoma. Okay. Patients with stage 3 melanoma have a high risk of recurrence despite optimal surgical management. Adjuvant therapy with targeted or immunotherapy is effective and decreased the risk of recurrence by roughly half. Certain patients in stage 2 disease could benefit from adjuvant therapy. We discussed this already, patient preference. I wish to have markers in the future. The safety profile of anti-PD-1s is generally favorable in these populations. It's funny enough, in stage 4 disease, often you have the notion that targeted therapies are well manageable and Ipilimumab is challenging. In adjuvant therapy, it's vice versa. There, the targeted therapy is really more toxic with the management as compared to the anti-PD-1s. The biomarkers, in addition to other risk modeling approaches, are needed to better optimize the risk-benefit profile. So this is something where academia is now required to solve this.
Okay, so we're going to go ahead and another twist in this case, and this is right up Christian's alley. So now Jessica has stage 3C disease with a palpable lymph node. 6 millimeter depth primary, 5 mitoses per millimeter squared, still no ulceration, but a palpable inguinal lymph node on exam, and it's PET-avid, and it's BRAF-mutated, and there's no significant past medical history. And we have neoadjuvant options of anti-PD-1, anti-CTLA-4, neoadjuvant BRAF-MEK, surgery and then adjuvant BRAF-MEK, surgery and then adjuvant anti-PD-1, and potentially other things. So go ahead, Christian.
Okay, thank you very much. This is my hobby, and I want to mention that we are coming now to an area where we don't have approved combinations or approved treatment. All that I show you are still experimental. Yeah. So first of all, do we want to give adjuvant or neoadjuvant therapy? And this is a review that we wrote some years ago for Nature Medicine, where we highlighted the concept of neoadjuvant immunotherapy. So if you remove the tumor and you start your immunotherapy in your adjuvant setting, then you have only micrometastases, and we know that they are less immunogenic, and then you will have in the periphery less tumor-specific T-cell patrolling. While if you in the neoadjuvant setting, and this was in 2014 when we started our journey in neoadjuvant, was only a hypothesis, then you have a broader immune response because you have the full variability of the tumor with all its danger signals that attracts also the T cells. You induce your immune response, you remove the tumor burden at the end, possibly even removing the tumor-induced immune suppression, and then you have a broad immune response patrolling through the patients. In mouse models, this has been shown, and also in the OPECIN trial, we have seen indeed this broadening of the immune repertoire. And this translates to a fantastic pathologic response rate of anti-PD-1 in the 75 for the pathologic response rates when you combine it, in about 34% if you give anti-PD-1s, and if you want to look at the PCR rate, then it's 20 versus 40%. So always twice if you give the doublet. And why is the pathologic response rate in the immunotherapy so important? Because if you achieve pathologic response, then your patients hardly will have a relapse. While if you don't achieve a pathologic response, then these patients, 2/3 of the patients will relapse. And I would like to remind you the neoadjuvant checkpoint inhibition is only 6 weeks. So after 6 weeks of treatment, You can tell your patient already whether he can build a house, get kids, marry, or whether we will be a little bit challenging in having a next year where we have to follow the patients very, very thoroughly that we detect the relapse very early. This holds true only for immunotherapy, and this is something what the FDA still has to learn, that in chemotherapy or targeted therapies, this clear surrogate marker is not so clear. Here you see now, for example, the PCR patients, they drop within 2 years to 80%, and interestingly, the partial responders, even they behave like the non-responders when you use targeted therapies. So this clear surrogate marker is exclusive for the immunotherapies. So here you see now the OPESCENT trial. I told you already, this is actually in melanoma the only trial so far that randomized neoadjuvant versus adjuvant, the double checkpoint inhibition. And it was a small trial from us that we designed, only 10 patients each arm. It was to show this, prove this hypothesis that I showed you in the cartoon. And indeed, we saw that the neoadjuvant arm expanded in the periphery way better tumor-resident T-cell clones at week 6 than in the adjuvant arm. What was also interesting is we saw a high pathological response rate of almost 80%, but, and it was also surprising to us, 90% grade 3/4 toxicities. We used the standard dosing that we used in stage 4 disease, and you clearly see that it seems that early stage disease is has less tumor-mediated immune suppression, and therefore also the bystander clones can give you a higher toxicity than what we know from stage 4 disease. To challenge this or to solve these problems, we decided a subsequent trial, the OPESCENT-NEO trial. 90 patients planned to be included and 30 per arm, now testing only 2 courses of the standard dosing, Ipi3 Nivo 1. Then in the arm B, the switch dosing with Ipi1 Nivo 3, and a sequential scheme with starting 2 courses of Ipi followed by 2 courses of Nivo. Surgery, no adjuvant therapy. And here you see now the summary of all this trial. Grade 3/4 toxicity for arm A, 40%. So by only reducing from 4 to 2 courses, we could reduce the grade 3/4 toxicity already from 90 to 40%. But very nicely, when we used the switch dosing, then it dropped to 20%. The sequencing did not improve as compared to arm A, the toxicity. And now comes the interesting question, can we preserve the efficacy? I told you we had 78% pathological response rate in OPESCENT, and this was the case. 80% in the arm A with only the 2 courses, but also the same 77% in arm B, slightly lower in the arm C. So therefore, this arm B was the winner scheme, only 2 courses, Ipi1 Nivo 3. Within 6 weeks, this patient is done with the therapy. And here you see now the relapse-free survival data and the overall survival data, and you see fantastic. I would like to remind you, this is a macroscopic melanoma patient population which has a relapse-free survival of about 30 to 40%. So we double the relapse-free survival, and the 5-year overall survival is normally with surgery only 50%. Also with this 6 weeks treatment, the overall survival dramatically was improved by this patient. And these were already 86 patients. I would like to remind you, every arm in CheckMate 067 was also hardly larger. So for a phase 2 trial, already pretty solid data. The incidence of immune-related adverse events also diminishes. It's hard to read, but what you see here is the grading and the grade 1 or 2 or 3 to 5, and the blue ones are the early ones within 12 weeks, and the red and the orange ones are the ones that are later ongoing with a follow-up in the beyond 12 weeks. You see that almost all disappear or go down to at least to grade 1 or 2. So here you see now the PRADO trial that we presented at ASCO this year. And this is actually an extension cohort from Opacin-Neo, because after we identified the winner scheme, we wanted to prove before we go to the phase 3 trial that this winner scheme is really indeed giving a good safety and efficacy profile. But to address only this question, I thought this is not worth for 100 patients being included. So we thought also what I've shown you with the pathologic response, that the major pathologic response patients have an excellent outcome. So can we reduce the toxicity also these patients from surgery by reducing the amount of surgery, and vice versa, if you have a no response, that we can increase the treatment of these patients. And let me go through with you. So the patients have undergone an index lymph node procedure. So we placed in the largest lymph node metastasis a marker. This could be a hydrogel marker or a magnetic marker. So just use that, what your breast cancer colleagues are always using. Don't try to invent the wheel again. Use that what you have in your center. And then after this marking of the largest lymph node, patients received 2 courses of Ipi, 1 Nivo 3, the winner scheme from Opacin-Neo, and then only the marked lymph node was resected. This can be done often also even in an outpatient situation, outpatient clinic situation. If you had a deep response, a PCR or a near PCR, thus the major pathological response less than 10% vital tumor, no therapeutic lymph node dissection was done, and the patients started right away the follow-up. If you had a partial response, 10 to 50% vital tumor, then the patients had undergone the therapeutic lymph node dissection, and the follow-up was started, no adjuvant therapy. If you had no response, then we escalated therapeutic lymph node dissection plus adjuvant therapy if you were BRAF wild type, Nivolumab if you were BRAF-Mutated, adjuvant Deptran. So here you see now the relapse-free survival, and this is for the whole cohort. This once more confirms Opacin and Opacin-Neo with the plateauing of the relapse-free survival at above 80%, with a distance metastasis-free survival at 89%. Of interest is now, what is the relapse-free survival and distance metastasis-free survival in the patients that achieved this major pathological response, where we omitted the adjuvant therapy and even the extensive surgery. And these data here. They are even better. You see the relapse-free survival was 93% with a distance metastasis-free survival of 98%. So hardly to beat, I think. So in conclusion, PRADO confirmed the first time the safety and high pathological response rate of neoadjuvant, and now in a large cohort of almost 100 patients. The omission of the therapeutic lymph node dissection and the omission of the adjuvant therapy in patients with the major pathological response was associated with a better quality of life. I haven't shown you this data, and resulted in the high 2 years relapse-free survival and distant metastasis-free survival rates that I've shown you. In partial responders, that I have not shown you, they had a higher relapse rate, and therefore we suggest now that partial responders, in contrast to the data from the International Melanoma Consortium, should receive adjuvant therapy. The addition of the adjuvant systemic therapy now in the non-responders improved strongly the relapse-free survival compared with historical data. Normally you have 2/3 of patients that relapse, and when we added the radiotherapy, and this radiotherapy was given synchronously with the systemic therapy, then we had only 1/3 relapses. So is this the only option? No. We have heard from Hussein already. The next KITS combination on the block is the PD-1 and LAG-3. I will not go into the mechanism once more, but I would like to show from this fantastic trial from MD Anderson, neoadjuvant PD-1 LAG-3. Pretty similar design, 30 patients, 2 courses, neoadjuvant 6 weeks, then the surgical resection. And the only thing is that all patients received also adjuvant therapy, so no personalization according to the response. very nice 59 pathologic complete response rate with a 66% major pathologic response. So pretty similar in the range of what we see for Ipilimumab and Nivolumab. We had for the week 12 a little bit similar or even worse toxicity profile, but for the long-term updated, this combination has even a better toxicity profile than Ipilimumab plus Nivolumab. We have now 2 trials that can be practice changes and can become or can be the resulting in standard therapies, neoadjuvant therapy. First, the SWOG S1801 trial. We have the control arm surgery followed by adjuvant Pembrolizumab. Here you see we give it now 6 weekly already, but this is in the trial still 3 weekly given, but it's for 1 year. And this compares to 3 courses, Pembro 200 milligram neoadjuvant, then surgery, and then adjuvant Pembrolizumab, filling it up till 1 year. So both arms receive the same amount of cycles, but this one here receives 3 cycles upfront surgery. Very nice trial, very clean, will clearly state the worth of neoadjuvant therapy. So the take-home message on neoadjuvant therapy, the use of neoadjuvant targeted therapy as well as single or dual checkpoint appears to be safe. Long-term benefit is superior with dual checkpoint blockade. The toxicity is highly dependent on the dose and schedule. The flip dose I showed you is currently the winner scheme that we have. The next generation strategies are focused on the limiting extent of surgical intervention, Prado, with this personalized adjuvant therapies.
So we'll get back to this case, and once again, this was a stage 3 melanoma patient with palpable inguinal lymph nodes, pretty deep primary, a lot of mitoses.
I think you are looking into the future. At the moment, we don't have it, but I think the neoadjuvant therapies will come, and the big advantage also is that you know what you're doing. You still can adjust your surgery and your adjuvant therapy. I love to see that you dare to go for the combination. What we have not shown here today is that the Nadina trial, which is running at the moment only in Europe, but will come also to the US, is testing indeed neoadjuvant doublet anti-CTLA-4 plus anti-PD-1, Ipi plus Nivo, as compared to adjuvant Nivolumab. So in that way, you are well prepared in your preferences already.
Yeah. So rather than ask you, Hussein, we're going to go to some of these questions which have come in. There's many questions and several that are marked important, so I want to make sure I get to them. And maybe these will be quick hitters. So either one of you, is the conversation about adjuvant immunotherapy different when counseling a stage 3 patient versus a stage 2 patient?
I think it's already challenging in stage 3, as long as we don't have OS benefit data. Considering what I told you, that the 20% absolute difference is now going to 8%, might become even more challenging in stage 2 disease patients. So there's a good discussion weighing the toxicities versus the benefit in currently relapse-free survival and distance metastasis-free survival are the most important points that you have to discuss with the patient.
Great. So Hussein, is Nivo-Rela appropriate for the BRAF wild-type melanoma patient who's failed Nivo-Ipi?
So we have data after PD-1 resistance of about 13% response. So it's a decent approach, but again we hope that we're going to be able to have other new options. I think if say Pembrolizumab lenvatinib gets approved, that has a higher response rate of 20%. TIL therapy, I think is something we should consider. But and we've actually been asked this question, and I've already faced it in our clinics. Our patients are savvy, so I have patients who have progressed. and show up in my clinic and said, oh, we heard about this new approval. Why can you give me that combination? And the truth is, you have the combination in hand. You can make an argument that you shouldn't use it because it's relatively safe and it can give some responses. So it could be appropriate, but I would consider other things, and I would take into account that the response rates that we see in the first line are not reflective of what you see in the second line. So it's more about 13% response in the second line.
But isn't it a time for a second DREAMseq trial? Ipi-Nivo followed by Nivo-LAG-3 versus Nivo-Rela followed by Ipi-Nivo in the BRAF wild-type patients. It would be a very interesting trial, but I know how hard times you had.
Yes. Well, there's another DREAMseq 2 trial that's being considered, and that's for the patient with BRAF mutant melanoma who progresses on adjuvant anti-PD-1. Mm-hmm. So how would you treat that patient, Hussein?
I mean, that's obviously a tough question, but the progression on adjuvant treatment depends a little bit on the timing of progression. So if you're being actively treated, receiving your anti-PD-1, and then you progress through that is higher. We consider it primary resistance, and we made those definitions through the SITC definitions that this is primary resistance. If you stop adjuvant immunotherapy and then a year later you recur, those patients still have a chance of responding to re-challenge with immunotherapy. So depends on the situation. If the relapse is in the brain, you want to make it harder on me. If the response is in the brain or progression is in the brain, then it's even more difficult. And again, you have to think about what are the tools that you have. What did the prior therapy teach you about the patient? What kind of phenotype are you seeing? And then use one of the tools that we discussed today.
Yeah. A couple questions for you, Christian. So would the flip dose strategy for Nivo-Ipi be useful in the adjuvant setting?
I think so, yes, definitely. Dirk Schadendorf with the standard dosing has seen, as what we had in the Opessin, a high amount of toxicity. So if I would design a trial in the adjuvant setting with the doublet, then I would also use the flip dose. But I would like to remind you, in the adjuvant situation, you don't know what you do, and then you have a combination scheme that potentially gives really more toxicity. I don't know whether this trial will come here.
Well, I mean, I was just going to say that trial will never happen, right? I mean, BMS just threw 1,000 patients on giving Ipilimumab at a sixth of the dose, which is the 1 milligram every 6 weeks, and it was dead negative. So we're never going to run that trial. And so I'd caution folks not to use the low-dose Ipi-Nivo as an adjuvant. There's just simply zero data on that in that regard.
What role, Christian, might radiotherapy have in augmenting an immunotherapy response? I'm bringing you back to your days at the University of Chicago.
We think of an abscopal effect when you give radiotherapy synchronously to the immunotherapy. Whether this in Prado, this fantastic effect comes from this additional radiotherapy, or whether it's only the adjuvant therapy, we don't know yet. This question will be addressed by the SWOG trial, because when we see in the non-responders also this reduction by the adjuvant Nivo about 2/3, then it's mainly the adjuvant therapy that we added. But we have done in this trial now first try all together to see whether at all we can rescue some of these non-responders, and de-escalating in the non-responders will be the next question indeed, yeah.
And at MD Anderson, Dr. Devarati Mitra, who's a radiation oncologist, is actually running a trial looking at the addition of nodal radiation to immunotherapy.
Okay, Hussein, what is the better sequence? I think they mean the best sequence, because they don't give us choices, of therapy for melanoma patients with high disease burden and an elevated LDH?
Yeah, I mean, I showed this morning in our subgroup analysis that you still get good responses with Nivo-Rela in that situation. But I will say that Ipi-Nivo remains our most potent choice. We know we have the highest response with that combination. So if a patient is progressing rapidly or symptomatic of their disease, with large tumors and you need a quick response, I still will rely on Ipi-Nivo. I mean, I think Ipi-Nivo still is going to be about a third of all of the patients that I treat, to be honest. So your point,
but would you pre-treat with BRAF-MEK or not? For short term?
Well, no, that depends on if the patient is BRAF-mutated or not. Honestly, if we have time, if the patient is, symptoms can be controlled with, say, pain medicine, I would prefer to give 6 weeks of Ipi-Nivo, learn what's going to happen there, potentially prime the immune system, and then if there's no response and they're BRAF-mutated, again, I consider BRAF-MEK as a tool that I can recur to at that point. In fact, you would argue that I'd feel more comfortable doing that because I have a salvage solution, right?
Yeah.
So I think we've gotten through most of these high important questions. I think the ones here that are also listed as important, we've already covered many of them in the presentations, and they came before the presentations. So I think we can end the program. Thank you again for joining us.
This activity is certified by PVI, Peer-Review Institute for Medical Education. Remember to download the slides and practice aids.